I'd first like to thank my teacher, Dr. Reggie, for giving me this opportunity to present ASCO and ASH updates. And I assure you it will get over very, very soon, very rapidly. So I'll first begin with the ASCO updates. I'll begin with the ARCHER trial. So this was obviously very, very special because it was comparing two EGFR TKIs. So it was comparing a second generation Dacomitinib, which is basically a second generation irreversible inhibitor. So it inhibits EGFR, which is HER1, HER2, and HER4. So this was compared against Geftinib in EGFR activating mutations. And here the endpoint, the primary endpoint was PFS. The PFS was statistically significant and in favor of Dacomitinib, where it was almost 15 months versus 9 months with Geftinib. But the issue here was dose reduction. Dose reduction was required in 67% of the patients receiving Daco, versus it was only 8%. Then I move on to the KEYNOTE-042 trial. So obviously this is going to add to the confusion that Ramanan sir was talking about, immunotherapy. So this was a trial. I'm only including some of the important phase 3 trials. So this phase 3 looked at squamous cell stage 4. And there were two arms. One was a chemotherapy where they gave either Taxol carbo or Pacli or Abraxane with carbo. In the other arm, it was chemotherapy with pembrolizumab in the same dose, 200 milligram Q3 weekly. And then they went on to also give pembrolizumab as maintenance up to 31 cycles. In the other arm, it was only placebo. So here the primary endpoint was progression-free survival, and here the median follow-up is short. It's only about 8 months. And again, they were able to show a significant PFS advantage in favor of immunotherapy, which was about 6.4 versus 5 months. And OS is not yet mature, but it was statistically significant. It was in favor of the Pembro arm. Then I'm moving on to the next trial. This was obviously very exciting for everyone. It was a soft and text update that was much awaited. And here they have updated the results after a median follow-up of about 9 years. So briefly, this was a trial that was basically taken up in early breast cancer patients only up to T2 and axillary node negative, hormone positive, HER2 negative. And basically, they did Tamox alone, they did Tamox plus ovarian suppression, and they did exemestane plus ovarian suppression. Now, initially when they updated the results and it came out in NEJM, there was no DFS advantage with when you compared it with Tamox alone. But now the story has changed, and here the endpoint is DFS. So over here, there was basically, when you compared it to tamoxifen, there was a 4% advantage when you gave ovarian suppression as well, and a 7% advantage when you gave aromatase inhibitor, that is exemestane with ovarian suppression. So here I'm just showing the results of the Tamox plus ovarian suppression versus exemestane plus ovarian suppression. The absolute difference was 4%, which is excellent. And freedom from distant recurrence, again, the absolute difference was 2%. So here this strongly, I wouldn't say strongly, but it favors exemestane plus ovarian suppression in the combined analysis. So this is the updated results on the ALEX trial. This was a phase 3 study that was taken up in ALK-mutated non-small cell lung cancer. So here they've compared crizotinib versus alectinib. They've taken about 300 patients. And the PFS is outstanding in the alectinib arm. It's almost 3 years. Whereas in crizotinib, it's a little less than 1 year. Brain metastasis in the alectinib was about 12% and crizotinib almost 3 times. The overall response rate was 83% with alectinib and 75.5% with crizotinib. So this, for me, was one very exciting trial. So this was the PREOPANC-1 trial. So pancreatic cancer, obviously, as we know in the West, is the 4th largest cause of cancer death. And the 5-year overall survival is only about 2 to 7%. And at presentation, only 15% are resectable. So here was a trial that was taken up by the Dutch. They basically looked at these borderline resectable pancreatic cancers, and they wanted to do a superiority trial favoring neoadjuvant chemoradiation versus straight surgery. So they've taken 246 patients, and they've given them they've either done CTRT, which was 36 grays of RT with gemcitabine, and then operated on the patients, or they straight away operated on these patients. Now, all of these patients received adjuvant gemcitabine, and the chemotherapy was the same on both arms. So the doses of gemcitabine were not necessarily higher in the first arm. And here the results, the median overall survival was the primary endpoint, and the p-value wasn't significant. In the CTRT, it was 17 months, whereas in the immediate surgery, it was about 13.7 months. The time to relapse, however, was significant. It was about 10 months in patients who received neoadjuvant chemo-RT versus about 8 months. The chance of surviving more than 2 years was 40% with the chemoradiation versus just 30%. Now, this is interesting. Patients in whom surgery was a success. The median survival was 42 months when patients received CTRT followed by surgery versus 17 months. And in this study, they did an upfront DLAP on all the patients, even if the patient was to have neoadjuvant CTRT. So this was another pancreatic study. This is the PRODIGE 24 study. And I apologize for the busy slide, but basically they took patients who were operated, either had an R0 or R1 resection, pancreatic ductal adenocarcinomas, and they either gave them adjuvant modified FOLFIRINOX. So in this, they've basically taken away the bolus 5-FU, and they've added growth factor. They compared that against gemcitabine, and their primary endpoint was disease-free survival. So just concentrate on this, the DFS, the 3-year DFS over here, the median disease-free survival was 22 months in patients who receive FOLFIRINOX versus 12.8 months. And when you come down to the overall survival, the 3-year OS is about 64% versus 50%. And the median overall survival with FOLFIRINOX was 54 months versus 35 months. Now, if you go back and think about the ISPAC-4 trial, in that they've compared GemCap versus Gem. So in that, the GemCap arm, overall survival was about 28 months. There, the median follow-up was slightly higher. It was about 44 months. Here, it's about 3 years. But obviously, toxicities were a major concern with FOLFIRINOX. So this was one of the plenary session topics. This was the TAILORX, which is again much awaited. This has come out some time ago. The initial study came out in NEJM, and as we all know, it is a 21-gene RT-PCR prediction in these patients with early breast cancer. So again, they've taken hormone receptor positive, HER2 negative, axillary node negative, early breast cancer, that is up to T2, and they had 10,000 patients. So initially, they've updated the results on the low range, that is up to 10. Initially, the low risk was up to 18, but when they did these studies in TAILORX, they've taken low risk as 0 to 10. Now, mid-range is about 65% of the patients, that's 11 to 25. Here, the median follow-up was 7.5 years. And the 9-year DFS in the entire, that is what they did in this mid-range was they either gave hormonal therapy versus chemo-hormonal therapy. And here, the 9-year DFS for both the arms was 83%, and the overall survival was 95%. So the final, I'll show you the slide first. So you can see there's absolutely no difference between patients who are receiving chemotherapy and hormones versus hormonal therapy alone. There's no difference in the invasive DFS and the freedom from recurrence at a distant site. But they were able to show that if patients were less than 50 years of age and required chemotherapy, they actually did benefit from the addition of chemo. So finally, in their conclusion, they've mentioned that chemo must be spared in patients who are above 50 years and a recurrence score of 0 to 25. This constitutes about 85% of women with breast cancer in this age group, and less than or equal to 50 years and a recurrence score of just 0 to 15. It doesn't go up till 25. Now, this was another plenary session topic that was discussed. This was KEYNOTE-042. So this was, again, it was a study that was done in locally advanced or metastatic non-small cell lung cancer. So it included both squamous and non-squamous. And here, they've compared paclitaxel carboplatin, or they've given pemetrexed carboplatin, or just pembrolizumab. And here the median follow-up is about 13 months. Now, irrespective of the PD-L1 expression, whether it was 50, 20, or more than 1%, they were able to show a favor, pembrolizumab favoring the results. So pembrolizumab, when it was more than 50%, was 20 months, versus with chemotherapy, it was 12 months. This is the overall survival. Again, they were able to show that the severe side effects when patients received single-agent pembrolizumab was only about 20%, and with chemotherapy, that almost doubled. So this was another session that was discussed in a plenary session. This was the CARMENA trial, which just came out some time ago in NEJM. So here they basically wanted to look at the role of cytoreductive nephrectomy. It was an open label, randomized phase 3, non-inferiority study design. And basically patients were randomized, they were stratified according to the MSKCC risk model and the center. And the primary endpoint over here was overall survival. Now they've taken 55% that are intermediate risk and 45% poor risk. Again, they had to publish their results without an entire recruitment. The recruitment was rather slow. So they've taken about 450 versus 576 that was initially planned. And here they were able to show that it was non-inferior. I'm not going to go into big details, but the hazard ratio for death was 0.89. And what they had planned as non-inferiority margin was 1.2. So they were not able to show a benefit. They were not able to show a benefit of cytoreductive nephrectomy in the intermediate risk and poor risk patients. This was one of the hematology studies that was shown in ASHASCO, again published in NEJM very recently. This is the INNOVATE-3 trial, the INNOVATE trial, which was a phase 3. So they've looked at patients with relapsed or refractory or treatment-naive Waldenstrom's macroglobulinemia. Now, as we know, in Waldenstrom's, there are two mutations. There's the MYD88 mutation, and the other one is the CXCR4 mutation. Now, in the initial studies, they did show that patients with MYD82 had very high responses with ibrutinib, whereas in CXCR4, it was much lower. Now, over here, they show that it does not matter. Whatever mutation status the patient has, the results are almost the same. So here they were able to show that in patients who they gave ibrutinib and rituximab versus just rituximab. So what they did was they gave 420 milligrams of ibrutinib, and rituximab they gave 375 milligram per meter square from week 1 to 4, weekly cycles, and then week 17 to 20. So there was a clear advantage. It clearly favored ibrutinib with rituximab. 30-month PFS was 82% versus 30%. So I'm moving on to the ASH updates. Now, all these trials have obviously come out, and we know everything about it, but I'll very briefly speak about just 3 or 4 of the studies. So this was the much-awaited ECHELON-1 study, which basically took patients that were previously untreated stage 3 or 4 classical Hodgkin's lymphoma. And in the study, they took 65% had stage 4. And they randomized 1350 patients to either AVD, that is doxorubicin, vinblastine, DTIC, along with brentuximab vedotin, which is an antibody drug conjugate against CD30. Or they just gave ABVD for 6 cycles. And here the primary endpoint was a modified progression-free survival, whereas the secondary endpoint was the overall survival. So they've reported the results after a median follow-up of 2 years. And they were able to show that there was a favor. There was a 4.9% advantage favoring the brentuximab arm. So the 2-year PFS was 82% versus 77%. At this time, they've not been able to show a difference in terms of overall survival. This might not be practice changing, obviously, taking the cost into account. But looking at the toxicities, now in patients who, with regard to peripheral neuropathy, patients in the brentuximab arm with AVD, the rate was 67%. But at follow-up, 67% actually reverted or started improving significantly. Whereas in the ABVD, it's about 40%. And what's most concerning is the pulmonary toxicity, which was of more than or equal to grade 3. In the brentuximab arm, it was less than 1%, whereas in ABVD, as we know, it was 3%. The most common cause of death in AVD, again, it was about 85%. 85% died of neutropenia, febrile neutropenias. So there was an amendment made, and they were made to give growth factor to all their patients after about 40% of the results were seen. And ABVD, again, 85% of the patients died of pulmonary toxicity. So this is another study that I think it has come out in NEJM as well. So this is a phase 3 randomized study which basically compared venetoclax and rituximab versus bendamustine rituximab in relapsed refractory CLL. So venetoclax, as we know, is it's an antibody against BCL2, which is an anti-apoptotic protein. So here they took about 400 patients. They gave venetoclax for 2 years, and the dose of venetoclax went from 20 to 400 milligram. They slowly increased it because of fear of tumor lysis. And the primary endpoint was an investigator-assessed PFS. So here they've reported the results after a median follow-up of 2 years. So again, a clear favor, a clear advantage in favor of venetoclax plus rituximab, where the 2-year PFS is 85% versus it's only 36% in the BR group. And 2-year overall survival also, they did show a statistically significant advantage. It was 92 versus 86%. And even when they looked at the 17p deleted patients, they saw a very similar result. And this is my last slide. This again has come out a long time ago in NEJM. This is the Alcyon paper that was much awaited. So here it was untreated myeloma patients, elderly myeloma who are not transplant eligible. They either continued getting VMP, that is Bortezomib, Melphalan, and PDN, versus the addition of Daratumumab, which we all know is a CD38 monoclonal antibody. So here, overall response rate was 90% in the Dara arm versus 74%. And obviously, all the multiple myeloma studies have moved towards MRD. So MRD was negative in 22.3% in the DVMP, and VMP it was 6%. And the 18-month PFS was 70% versus 50%. And here they've reported the results after a median follow-up of 16 months. The other trial that again was discussed in ASCO and also ASH was the results of anti-BCMA, which was much awaited for myeloma, that is CAR-T in myeloma. So that is against the B-cell maturation antigen. So there they were able to show the patient population was very poor. 30% had penta-refractory disease, and they showed an overall response rate of 95%. Unfortunately, these patients also had a median PFS of about 17, 18 months. So it's not like we're achieving long-term cures with CAR-T also in myeloma. Thank you.
Thank you, Nikita. I think that was a real rapid session, and she'll come back at the last again for some interaction.